Good morning, everyone, and welcome to the webinar. Today's topic is the POLST form, what it is and how to use it. And we appreciate you joining us today. These complimentary webinars are brought to you through a collaboration of services and sponsorship with O'Connor Mortuary, Care Choices Hospice and Palliative Services, Caring Companions at Home, Hoag, as well as Alzheimer's Orange County. My name is Kim, and I'm a gerontologist here at ALS OC, and I will be your host today. Our sponsors are providing these webinars to you as a service to the community on topics that are beneficial for anyone who cares for and works with older adults. We hope that you find today's presentation especially informative and useful. Today, our presenter is going to be our own Patty Mouton, and I will tell you about her in just a few minutes. But before I do, let's go over what you need to know about getting CEs today. Next slide, please.
I'm sorry, can you see the screen share yet?
We see this, we're on the first slide. If you'll just advance to the next one, that'd be perfect, Patty.
Okay, I can't see the slides. So I,
Uh, oh, okay. Well, just click on it and then hit your arrow button.
how's that?
Nope,
Okay, I'm sorry, I am having a little technical issue, so
no problem. No
hang with
problem
me.
at all. Let me go ahead and talk my way through this slide while you figure that out. We have CE credit that is available for RCFE administrators, licensed RNs and LVNs, and for LMFT, LCSW, LEP, and LPCC professionals through CAMP and the BBS. You must be online for the full 60 minutes. You must have access to both audio and visual on your computer. If you want CE credit, do not share your link with others. This is your unique record of attendance. If you share your link or use another attendee's link, unfortunately, you can't receive the CE credit. There are a series of poll questions which we would like you to answer immediately as soon as you hear me express them. Go ahead and submit your response. If for any reason at all you have technical difficulties, you can always put your answer into the chat box. But again, we need to know that you're attending and that you're online with us and participating. So please do answer the poll questions promptly. Also, complete the survey immediately as you exit the webinar. You'll only receive a survey link by mail if you don't complete the survey when exiting the webinar. So the email with the survey link is sent out 24 hours after the end of the webinar. And this link, again, is unique to you and your attendance. So please don't share it with others. Okay, so can you maximize your slides, Patty?
Um, I'm, I believe so. There you go. How's
Okay,
that?
and then go ahead and advance. Okay, and
There we
advance
go.
one more time so I can say beautiful things about you. All right, so let me tell you a little bit about today's presenter, and she really is so well known in the community to most of you. But Patty Barnett Mouton serves as Vice President for Outreach and Advocacy at ALS OC, where she's been on staff since 2005. In January 2020, Patty also assumed responsibility for the Advanced Care Planning Education Program for the Hoag Hospital Palliative Care Department. Prior to 2005, Patty worked in hospice care for several years and held leadership positions with the American Red Cross Blood Services and in business development with divisions of Johnson & Johnson. She has served as co-chair of the Orange County POLST Coalition, now known as the OC Advanced Care Planning Partners, since 2010. She serves on the Provider Advisory Committee at Cal Optima, chairs the Older Adult Work Group for the OC Veterans and Military Families Collaborative, and has served on the board of the Sacred Dying Foundation. Patty currently serves on the OC Older Adult Advisory Commission to the Orange County Board of Supervisors, is part of the Leadership Council for the Caring of the Whole Person initiative at the Orange Catholic Diocese, serves on the Senior Citizens Commission for the City of Laguna Niguel, and has served as chair of the Public Policy Committee of the Orange County Strategic Plan for Aging / OCASC. She holds a BS in Human Services from Springfield College, graduate certificates in Fundamentals of Gerontology and Palliative Care Chaplaincy, and is currently a candidate for a Master's of Gerontology at Cal State Long Beach. She is a clinical POLST educator and is on the End of Life Nursing Education Consortium faculty. So we are so pleased to welcome Patty Mouton. And Patty, it's all yours. I'm going to hand it over to you. Thank you
Great.
so much.
Thank you so much, Kim. This is really fun. And I want to let you all know that this 1 hour presentation we hope will be really beneficial for you. There is also a brand new POLST Champion program through the Coalition of Compassionate Care of California. It is a multi-hour, about 20 hours of training, and there is a pretty significant investment, but it's an excellent curriculum. And I've put their website in the chat in case any of you are really interested in becoming more fluent and more able to teach about POLST. It's a great program. So let's talk about POLST. What is it and what does it mean? It's an acronym. It stands for Physician Orders for Life-Sustaining Treatment, and it encourages communication. It gives first responders concrete instructions of what kind of care people would want if they're in a healthcare crisis or if they're at end of life. Because most of the time, patient wishes are not known. And we'll talk about this more as we go, but I think it's pretty amazing that 2/3 of Californians say they would like a natural death, but only 7% say they would want everything done to prolong life. 60% say they want their families not burdened by tough decisions, but only about 7% have actually talked with their doctor or their families about it. It's really amazing that we have such low participation, but part of our education efforts and part of your education efforts for the people and the patients that you serve is to talk to them about it, because we don't know what people want unless they have put it in writing and told people about it. The Advanced Healthcare Directive may not be accessible. The Advanced Healthcare Directive does not provide physician orders, and their wishes may not be clearly defined, because would any of you be able to actually define heroic measures or extraordinary measures? Of course not. That's why we need the POLST. It allows healthcare providers to really know what somebody wants in very specific clinical detail and be able to honor it through this medical legal order. Because being hopeful is not a plan. Having a tattoo that says DNR on your chest doesn't work. And across the country, less than 25% of people have actually put any of their healthcare wishes into writing. So we need to help them do that. We need to be prepared, because nobody is ready to make critical healthcare decisions in a crisis. And it's really not fair to anyone, including the patient, but also the first responders and the healthcare personnel, for people trying to make decisions as the ambulance is arriving or as the life flight helicopter is landing. We need to know these things ahead of time in order to really pay attention to what is it that people want. And we plan for everything. what do we plan for advance for? Well, we plan baby showers, we plan for our taxes, we plan for school, we plan for when we're going to vacuum the house. We plan. Uh, Human beings are planners, but they don't look at these issues. So we really want people to think about what levels of care would they consider acceptable, and what does that mean to them? What does extraordinary measures mean? Do they understand the difference between the benefit of potential treatment and what are the burdens? What might be the downside of choosing aggressive treatment? Have we talked to our family members? You would be shocked to know how many people raise their hand when we say, do you have a family trust? Do you have an advanced healthcare directive? Oh, yes, they raise their hands. And then we say, how many of you have actually given copies to the people that you have noted as your healthcare agents? And the hands go down. How many of you have actually spoken to your families about critical issues like, do you want CPR? More hands go down. And who would speak for you if you could not speak for yourself? Critical component of the Advanced Healthcare Directive. And many people have never told their healthcare proxy decision maker that they've named them in either their healthcare decisions or in their family trust. So the POLST requires this consortium of legal decision maker, patient, healthcare professional to all confer, pardon me. And we encourage a great deal of conversation as the forms are being completed. And then once they are completed, talking about it with people important to you in your life, talking about it with your loved ones. Sometimes it's really important to talk about it with your neighbor across the street, even if you don't really like them, because they might be the person calling 911 if you have a heart attack when you go out to get your mail. So you really do need to think about who needs to know what you would want in the event of a healthcare crisis. The POLST is very, very specific. It's not for everyone. And it is absolutely not appropriate for every person coming into a skilled nursing facility, for example, because they're recovering from a hip replacement or a knee replacement or some other kind of surgery and they're expected to get well. The POLST may not be appropriate for any of those folks. So we have to think about it's for a specific population, people with chronic, serious, progressive illness, people who are medically frail, perhaps for people of very advanced age. And I tell the story about my mom. God love her. She passed away at the age of 97. She was sick for 9 days on hospice before she died. She wasn't expected to die, but she was 97. So should she have had a POLST? Absolutely, because no one was surprised that she didn't make it to her 98th birthday, because she had already outlived what everyone's life expectancies would be, and certainly the norms for our communities. So if someone is at a very advanced age, consider this surprise question. That's kind of our benchmark. Would you be surprised if this patient died within the next year? And if you say no, then they probably need to have a POLST. But certainly people with serious illness and other types of chronic conditions that could cause a precipitous decline. POLST is something that really allows people to think about and then choose what they would want. And, we have to think about things in kind of granular detail. Pardon me. Do we want to attempt cardiopulmonary resuscitation? And that language is really important because think about it. On whom do we perform CPR? People who have no heartbeat, no pulse, and they're not breathing, otherwise known as dead. So it's not a guarantee we're going to bring him back. It's an attempt to get that heart going again. And it doesn't work all the time. And it definitely doesn't work to bring people back to their previous level of functionality all the time. It was not designed for people who are medically frail. CPR was designed to save surfers and lifeguards and swimmers in the ocean who hit their head on a sandbar and start to drown. It's more for the young, healthy, robust individual as opposed to the really medically frail person. People don't understand what it means to be on a ventilator. It's a brutal procedure. You can't talk. You maybe have to stay sedated so that you don't try and pull out the tube. It's kind of a really harsh, invasive kind of treatment. Wonderful if people can't breathe on their own and we think we're going to get them better. And sometimes it's miraculous, but it's also not for everybody. Sometimes people don't want IV fluids, artificial nutrition. Maybe they want antibiotics if they have an infection toward end of life. Maybe they don't. There's also space on the POLST to add some additional orders or some modifiers, perhaps to try CPR, perhaps to try using a ventilator for a short period of time, perhaps to administer antibiotics under specific circumstances. So this is why it's important that people not only understand what it can do for them, understand their wishes and the clinical implications, and then have an opportunity to have a conversation with a healthcare professional in order to make a really advised, considered decision. It's never mandated. The POLST is always, always voluntary. And this is important, particularly if you work in a skilled nursing facility, because on the MDS information, there's a box or a question and boxes that say, does the patient have a POLST? Yes or no. It's okay to check no. And I think a lot of staff in skilled nursing facility situations feel like because there's that question, they need to have it be marked yes. And that's not the case. No is an okay answer, particularly if the person is not appropriate for the POLST form. So let's talk about a patient's story. What do we wish we'd known? Mr. Jones is an 83-year-old man with severe congestive heart failure. He's living in a skilled nursing facility after a hospital stay for pneumonia. He developed increasing shortness of breath and decreased responsiveness. The skilled nursing staff called 911 for patient transport to the hospital. The emergency department physician couldn't find any code status or other information in the paperwork that was sent by the skilled nursing facility, so he assumed this patient was full code. Mr. Jones required intubation and was transferred into the ICU. Pretty dramatic. Poor Mr. Jones. What do we wish we had known? Well, what we didn't know is that he had an advanced healthcare directive and he had a POLST, but it wasn't with his proper paperwork. It was at his home, and it was probably locked in a special desk drawer or a fireproof box. He was doing what he thought. He'd been asked about it at admission, but his family hadn't brought it in to add to his SNF paperwork. So it wasn't in his medical record. He talked with his family and the SNF staff about his desire not to go back to the hospital, and they didn't want to receive really aggressive treatment. There was documentation of this in the nurse's notes at the SNF, but not in any documentation that was sent to the hospital, and not in any form that could be actionable for the staff at the emergency department. So think about that. And his family couldn't be reached. So this gentleman got a lot of treatment that was not what he wanted. So it's important that we keep this in mind because advanced healthcare directives are great, but unless we discuss them with our family members and the people that we've designated to make decisions for us, nobody's going to know, and we can't read your mind. If DNR wishes are not documented in a readily accessible legal form, we can't abide by just that verbal unless you have a person from the family or a recognized decision maker there to advise the providers and the staff. So this patient got overtreatment, which was against his wishes, and he was subjected to some really unnecessary pain and suffering. So we had a system-wide failure to document and honor this patient's wishes, not a consistent, recognizable plan. And so it's really tragic that his wishes were not communicated appropriately. So the POLST is a medical legal order that's recognized throughout our healthcare system. Emergency medical services paramedics have blessed the POLST since 2009. They have participated in the updates that have happened along the way, and there have been about 3 different major updates and revisions to the POLST form since it was passed into law 2009, 2010. It should be portable so that it transfers with the patient. It is the most obnoxious hot pink, and that's so that it will stand out in a package of papers or in a paper chart. It can be copied. It can be valid if it's a screenshot on someone's phone. It can be entered into the electronic health record. And we really suggest that that's what people do. And it allows people to very specifically choose and avoid treatments that they do or do not want, and provides very, very specific direction for the healthcare providers, talking about a range of treatment options during serious illness so that the providers can provide the treatments that the patients do want and avoid unnecessary treatment and avoid unnecessary pain and suffering. Who benefits? People with chronic progressive illness, people with a serious health condition, people who are medically frail, people who are at advanced age. And remember the surprise question. Someone not fitting into one of these categories may have a POLST form if that person and their physician agree that it's a good idea. There's no age specifications. It can be used with both adult and pediatric patients, but it's such a helpful tool. And it becomes a really important opportunity for conversation to specifically address what would you want under these kinds of circumstances in a medical crisis kind of situation. So we have our first poll question.
Okay, let's see what it is. The POLST form allows individuals to choose both the medical treatments they do and do not want to receive. Is that true or false? Audience, go ahead and select your answer quickly and submit it. Once again, it's a true false. The POLST form allows individuals to choose both the medical treatments they do and do not wish to receive. Let's go ahead and close the poll and release the results. I think everybody's weighed in and everybody did a fantastic job on that. So thank you, and back to you, Patty.
Great, thank you. Okay. Okay, my slide is not advancing. Here we go. There we go. I love it. All right, so in a study done from patient information from Oregon, 58,000 deaths were reviewed. 31% of that population had a POLST in the Oregon registry. And patient treatments were honored, including avoiding dying in the hospital. And people have wishes um, for um, for in-hospital death with comfort measures only, 6.4%. I think that's kind of interesting. Opted for that, and that's what they got. For patients requesting full treatment, about 44% died in the hospital. And for people that wanted limited interventions, about 22% died in the hospital. But for those with no POLST form in the registry, 34% died in the hospital. And the study found that those with POLST comfort measures only orders, they were significantly less likely to die in the hospital compared to those asking for more full treatment. And full treatment patients were almost 10 times as likely to die in the hospital than those people that opted for comfort measures. So it's important that people understand what this means for them. And, you know, if you're like me, I think about, where do I want to be when I leave this planet? I have a whole scenario in my mind. I want to be in my own room, in my bed, with my pretty pillows, my little dogs at the foot of the bed, maybe a couple of grandchildren around. I'd like my husband to be there. Maybe everybody's had a cup of tea and we've played some music, and then I can just drift off. Wouldn't that be lovely? You don't get that unless you make your wishes known. And I think we don't stress that enough with the people that we serve. POLST became effective in 2009 through legislation, and some of the most recent updates happened in January of 2016. And that's important because it allowed nurse practitioners and physician assistants to sign and execute the POLST fully. And I think that's an important consideration. In California, there's one form for the entire state. It is never mandated. It is always voluntary. But if somebody has an appropriately executed POLST form, there's a legal responsibility to honor the wishes on that form, unless there is some very significant reason for the physician to insert different clinical judgment. And that doesn't happen very often. It also provides immunity from civil or criminal liability when healthcare practitioners follow the POLST when it is properly executed. And I think that's important to keep in mind. Providers must follow the POLST except if it's contrary to generally accepted healthcare standards or medically ineffective treatment. An example is if someone is critically ill and treatments requested on the POLST form either will not help the person or can cause more harm than good. The doctor should then discuss this with and an appropriate plan of care, either with the patient if the patient is coherent and understanding, or with the family and designated decision makers. So it's a really important consideration if we're ever going to use different judgment than what is articulated in the POLST. The POLST is complementary to People's Advanced Healthcare Directive. It does not replace it. And this is really important. The Advanced Healthcare Directive has really one legal job, and that is to name the person who would speak for the patient in the event they cannot speak for themselves. It doesn't attach unless the patient cannot respond and speak for themselves. And people sometimes put lots of extraneous information in their Advanced Healthcare Directive. They say things like, no carnations at my funeral. I want to be cremated. All kinds of things that really are not legally binding in that form. So the Advanced Healthcare Directive has one job, and that is to name the person who speaks for the patient in the event they cannot speak for themselves. The POLST then becomes kind of the next level of decision making and very specifically articulates people's wants and needs. So a comparison of these two legal documents is the advance directive is for anyone over the age of 18. And if you've ever heard me give the advanced healthcare directive presentation, you'll know that I talk about raising teenagers. And all of our kids are all well grown up and way past all of these issues for us as decision makers. But let's say you had a 20-year-old who goes away to college, and 2 weeks into the semester, they fall in love and they start cohabiting with this love interest whose tattoos may or may not be spelled correctly. And you don't have any knowledge of this person. You know they're dating somebody, but you don't know the seriousness of the relationship. And your child, your 20-year-old, has some sort of catastrophic health event, perhaps an accident, perhaps some other major health issue. They can't speak for themselves. They're transported to the emergency department, and this partner, this love interest of theirs, shows up behind the ambulance and says, "Well, I live with her." Guess who the providers are going to listen to when making healthcare decisions? Because maybe they don't know to contact you, the parents. So unless your 18-year-old has an advanced healthcare directive that names you as the parents, as the decision makers, this person that you don't even know, again, whose tattoos may or may not be spelled correctly, could potentially be making healthcare decisions for your 20-year-old child. That's why it's critically important. Anything can happen, and we don't want to think about it, but it's really important to be prepared. The POLST, conversely, is for people who are seriously ill. Perhaps they're at an advanced age, but it can be used for pediatric patients, can be used at any age. It's for specific orders for treatment that could happen today. The Advanced Healthcare Directive gives some general instructions for future treatment that may or may not be legally binding. So the only legally binding job of the Advanced Directive is to name the decision maker who speaks for that patient. The POLST can be executed, signed by that decision maker. So that's an important distinction. Where does the POLST fit in? Well, this is a really nice schematic. If you're 18, you should have an advanced directive. You should update it periodically, at least every 5 years, or if there's some real major change in life. You've moved, you've gotten divorced, somebody in your family who might have been a decision maker has died, whatever it happens to be. These documents should not be just filed away and you don't think about it again until there's a crisis. They are dynamic, living parts of our care plans. And so we should know about it, talk about it, and dust off the copies at least every 5 years. If we have a serious diagnosis, serious cancer, serious COPD, heart failure, anything that could be considered a very serious chronic illness, then perhaps a POLST form is indicated. And that then would enable the healthcare professionals to know what wishes to honor, how to plan care. POLST allows for choosing resuscitation. You contrast it with the pre-hospital DNR that is still in use occasionally. The pre-hospital DNR is only for resuscitation, and it's only offered on the way to the hospital, and it's for specific situations. The POLST covers a person for the course of their illness unless they change their mind and fill out a new form. But the POLST also very specifically articulates other kinds of treatments that people would or would not want. And the POLST is honored across all healthcare settings, honored in assisted living situations, honored if the paramedics come to your home. It's more of a universal, categorical articulation of patient's wishes in this medical legal form. There's also that preferred intensity of care document that is sometimes still used in skilled nursing facilities. Again, the PIC form is going to be different in every facility. It's not a legal medical order. It's like a doctor's note. And it's really only appropriate to be used inside the skilled nursing facility. Whereas the POLST form is consistent throughout California. It's a medical legal order, and it should be honored across all healthcare settings. Both include choices for certain medical interventions. The POLST replaces a PIC form, and the POLST is always, always voluntary. And I think that's a really important part of the process. Let's look at our next question.
Okay, it's time for our next poll question. And I'm having a computer issue here. Lauren, do you want to read the poll question? Oh, there it
Sure.
is. It
Okay.
came back up. Today's our day for technical difficulties, right? It's a true false. The POLST form is always a voluntary form. Is that true or false, audience? Go ahead and quickly weigh in. Once again, it's required to show that you're actively participating. So choose your answer. If you have any glitches, you can put the answer into the chat box. Okay, it looks like just about everybody's weighed in. How did we do? All right, we did great. Let's keep moving and turn it back over to you, Patty.
All right, very well. Okay. So here's what the POLST looks like. Let's take a look at it. If you have a copy, pull it out. And if not, it's something that we can send to you, and make sure that you've got one, even if it's just for your portfolio to be able to speak to when you're talking to families. It's this ultra hot pink color, and it's almost always on cardstock paper just to make it a little bit more durable. Copies are legal and actionable. A screenshot on your phone is actionable, but you have to have both sides of the POLST included. It can be put into the electronic health record, and it's important that people who are really very ill, that they have shared copies of this POLST with people in their lives who could be part of responding to a healthcare crisis. This is the backside. Minimum requirements are the patient's name, first and last, legal name, that's important, date of birth. We want to make sure we've completed all the sections. And then on the back is the name of the person who has had the conversation, the preparer's name. The front side needs to be signed by the physician, nurse practitioner, or physician assistant. If it's not signed appropriately and we don't know who this physician is because we can't read their name, that could be a questionable POLST document. So that's a really important thing. And it is never, ever, ever, ever appropriate for a healthcare provider to sign it in advance and then tell somebody else to have it filled out by the patient. That is a really inappropriate use of the POLST form, and it should never happen that way. So if that's ever happening where you're working, call attention to it and let them know that this really means that that POLST form is not actionable because there hasn't been an appropriate conversation. So it's not a check the box one and done. This is a complicated decision-making form. And remember, if you're copying or entering into electronic health record, be sure to use both sides of the form, because without that, it is not actionable. Let's look at the first part. You want to be sure that you have everything completed appropriately, spelling, don't cross out anything, don't make corrections on this form. If you can help it, it's really important that the form be completely clean and filled out appropriately so that you don't have changes, because that can negate the form, and it should. Because if I were a paramedic responding and deciding whether or not to start CPR on someone, and their POLST form had a whole bunch of scratches on it, or no, see this, or a change in the date, or anything on that form that wasn't 100% pristine, I would err on the side of giving CPR, which may or may not be what the patient wanted, but the POLST would not then be considered actionable. So filling it out completely is really a critical consideration. It's important that it be dated, because sometimes people change their mind, and there might be two POLST forms in the patient's medical record. They could be conflicting. What healthcare professionals would then do is use the most current form. And I usually tell people, if you are going to change your original POLST form, keep the old form, complete the new one appropriately, put a big black line through the old form and staple it to the back of the new form, so that if anybody has a question about, oh my gosh, there's a POLST in the chart and it's different from this one, you can present them with what is the updated copy. And then you don't have that consternation about which one is the most current or the most valid. Section A, really important. Section A indicates, do you want us to attempt cardiopulmonary resuscitation? Or do you want us to not attempt resuscitation and allow natural death? This is critically important because it helps to inform the process of filling out the rest of the form. Because if somebody says, I want you to attempt CPR, we're not going to just give them CPR and do nothing. Now we have to look at life support. Oh, I'm going to sneeze. Excuse me. Excuse me. Oh, goodness. Okay. The patient has no pulse and is not breathing. That's what Section A looks at. Do we attempt CPR? And remember, the language is important, because everybody thinks if you have cardiac arrest, George Clooney is going to magically appear, do CPR, maybe do external defibrillation. I can just hear George yelling clear, and they think everything is going to be just fine. And they don't understand that at the end of the episode, they're not going to be having a cheeseburger and a beer with old George. You may or may not come back as a result of CPR. And if we do get that heart beating again, you may or may not regain your cognitive function. So that's an important consideration. People need to understand CPR is not magic. So if you choose CPR, you automatically have to have some full treatment, because we've got to do basic life support. We're not going to just start the heart up again and then not do anything else. If a person chooses do not attempt CPR in Section A, they can then opt for full treatment, selective treatment, or comfort-focused treatment, or treatment for a trial period. But that's why Section A is so important, because it pretty much governs what's going to happen next if you choose CPR. So you have to understand that you choose for us to attempt CPR, then you're going to get basic life support until other decisions and plan of care can be made. So that's a really important part of the process. Section B, the medical interventions. Well, okay, maybe somebody does want CPR and they want full treatment, but for a trial period. Maybe they are very, very ill. Maybe they have a terminal cancer. But if their heart stops, they want to maybe see if they can be brought back and maybe have full treatment for a period of time. And let's give them an opportunity maybe to get well and to wake back up. Maybe they have a wedding that's 3 weeks away, or maybe there's a new baby coming and they want to have an opportunity to live long enough to see that event or that new baby. They could also opt for selective treatment, which is a goal of treating medical conditions, but not the really heavy, burdensome measures. So, maybe they have some complications. Maybe they don't want to undergo full burdens of treatment. Maybe they don't want intubation. Maybe we use CPAP or some other kind of positive airway pressure. Maybe they don't want to go into intensive care. Maybe they don't want to go back to the hospital. Maybe they only want to go to the hospital if we can't control their pain or other symptoms. So, this is where a rich conversation comes into play. Or maybe they want only comfort focused treatment, where the primary goal is how can we make this person comfortable knowing that the potential for natural death is imminent, and what would they want, what does it look like for them? So that's why it's important that these conversations be very, very distinct and in depth. Maybe people want cardioversion, but they don't necessarily want it tried again and again, and they don't want to have to go to the ICU. Maybe they want manual treatment of an airway obstruction. It's really going to depend upon their condition, their values, what their goals of care are, and it could change over the course of their illness. And that's important that people know. Once you fill out a POLST form, that doesn't mean you're tied to it for the whole duration of your illness. You can change your mind, and that's perfectly okay, because under certain circumstances, you might want to have CPR. And then for section C, this is where we determine, do people want artificially administered nutrition? What if they can't eat very well? And this is particularly important and poignant, in my opinion, for people with end-stage dementia, because many times how we know that they have really transitioned to end stage is they're losing that ability to swallow. And there's a great danger of aspiration pneumonia. And they just can't take in enough food and fluid to sustain life. In many cases, this is Mother Nature's way of allowing the body to shut down in a very gentle and natural process. But sometimes it's very hard for families to not want to put in a feeding tube. And this is where very compassionate conversations need to be really, really important in this process to help people understand what are the burdens and the benefits of treatment. What potentially could this person benefit from if we did put in a feeding tube or give them artificial nutrition? What are the downsides? And if you don't know the downsides of artificial nutrition and hydration at the end of life, let's talk about that for a minute, but also come to one of our end of life in-services, because the body can't process all that fluid or all that artificial nutrition. And sometimes it just builds up. Sometimes they have terrible reflux and they have aspiration pneumonia anyway from the reflux and regurgitation. Sometimes it causes ascites, painful fluid swelling in their abdomen. Sometimes it's a fluid overload on their heart. Maybe they didn't have congestive heart failure before, but now they're at the end of their disease process and their little heart is failing. Well, that can put a lot of stress on their heart. So it's not a decision to be made lightly. It needs to be made in context of their overall health condition, their decline, and what is the prognosis for them getting better. If there isn't a good prognosis for somebody to really get better, then maybe a feeding tube or artificial nutrition is not the right thing to do for them, depending upon their own values and goals of care. It's not just a checkbox form. This requires a lot of conversation. And it's really incumbent upon us as professionals, if we are tasked with having a POLST conversation. First of all, if you are ever having a POLST conversation with a patient, you need more training than this hour is going to give you. And I think that's an important consideration. The training to really have a POLST conversation with a patient or patient's family is many, many hours and a lot of practice. And that's the kind of thing that we shouldn't take lightly. This is not for a social work designee to have a conversation when somebody's being admitted to a SNF for their knee replacement recuperation and rehab. This is an important conversation about identifying goals of treatment. And we have to think about how we position medical examples that could happen in the future that clarifies people's goals of care. People don't think about it. If you say, well, what if you developed a really, really serious case of pneumonia? And that then becomes a conversation about decisions they would make in section B of their POLST. We have to become more fluent at those kinds of consideration, because just saying what kind of care would you want isn't enough. And it's not enough to appropriately execute a POLST form. So who can help a patient or legally recognized decision maker with a POLST form? It should be someone licensed, certified, or otherwise authorized with specific kinds of training to provide healthcare in the normal course of business. And the best practice indicates that only those who are very specifically trained in the POLST conversation be put in this role. Chaplains sometimes are very well trained. Social workers could be very well trained. Physicians, nurses, physician assistants, nurse practitioners, all of these folks could have the appropriate training to have an appropriate POLST conversation. But it's not here, sign here, everyone has to have one, not appropriate. And I think we need to kind of take a step back, because all too often that has become more of the norm. So section D, information and signatures. It's very important that this be completed completely, accurately, and without corrections, particularly if the person signing on the patient's behalf is their legally recognized decision maker. It could be the person that they have specifically noted in their advanced healthcare directive, or if they didn't have an advanced directive, it could be someone that the healthcare team recognizes as a legal decision maker. Could be a family member. It could also be that person with the misspelled tattoos that shows up behind the ambulance of your 18-year-old kid. So that could be an issue. So who can speak for the patient? Well, certainly an identified decision maker or agent, their parent, their registered domestic partner, their guardian, their conservator. It could be the closest available relative. It could be a good friend that maybe is their only friend in the world that shows up at the hospital and shows concern, and the healthcare team believes that this is someone who could be making decisions for the patient. But in California, there's no hierarchy of surrogate decision maker, except if it's in writing in their advanced directive. So if a whole bunch of family members show up, it causes a problem, a conundrum for the healthcare team. And so new legislation passed in 2023 allows the healthcare team to determine among this cohort of family members, they can pick one person to be the decision maker if it has not been otherwise identified. This authority is granted for that particular episode of treatment for a limited time, either 60 days or the resolution of the healthcare episode, whichever is shorter. And the authority of the designated surrogate decision maker takes priority because that's what the healthcare team has to deal with. But it's important that people know this, that it's not the oldest son. Sometimes it's not the mother or the father. If the mother or the father don't understand the clinical information that is being relayed by the healthcare team, then the healthcare team may say, you, the 25-year-old graduate student who understands what we're talking about, or who knows the definitions of some of these treatment options. So they can make a considered decision and choose the healthcare surrogate decision maker. It establishes a formal process for identifying a surrogate decision maker for people who are incapacitated and have not appointed someone via an advanced healthcare directive. And it could be any one of this particular group of people, but the choices are not prioritized in any kind of hierarchy of relationship. And this is important, and it is time limited, either to the course of that particular episode and stay in that facility, or 60 days, whichever is shorter. And then there's the backside. Well, this just ensures that we know who had the conversation with the patient. If it is a nurse practitioner or a PA who is signing the form, we want to know who their supervising physician is, and that needs to be legible. The person having the conversation needs to be indicated. That would be the preparer. And I'm not a clinician, but I have been trained to have a POLST conversation. So there have been many, many families for whom I have helped them complete their POLST document, and then it goes to their healthcare professional provider for signature, and hopefully there's an additional conversation before the form is completely executed. So that's really important. Again, it's voluntary. It does not replace the Advanced Healthcare Directive. It allows people to make very specific choices according to their values, their goals of care, and it's only for people for whom no one would be surprised if they died within the next year. An incomplete section of the POLST reverts to full treatment for that section. But it's not a good idea to have any sections that are incomplete. So we really want this to be executed completely, accurately, neatly, legibly, and without a bunch of corrections. That's very important.
Patty, I need to interrupt you just for a moment.
Yeah, oh, we're almost out of time.
We are at just about at 12:30. So what we would like to do is to go ahead and release the final poll question in case some people need to leave at 12:30. And so everyone, we are going to do the third poll question at this time, and it is a true false. The POLST form facilitates important conversations among patients and families. Is that true or false? The POLST form facilitates important conversations amongst patients and families. Please go ahead and answer that quickly. Okay, let's go ahead and share those results. 100%. That's
Hot
excellent.
job.
Okay.
Good job, everybody.
But before we go back to Patty, I just want to mention that some of you may have questions for her. You can put those into the chat box. We're still going to do a Q&A, and we invite everybody to stay over a little bit if they're able to. I also just want to take a second to thank our supporters who are O'Connor Mortuary, Care Choices Hospice and Palliative Services, Caring Companions at Home, and Hoag Hospital. Thank you so much.
And I will very quickly go through our recap. It's very important that the POLST be revised periodically, at least every 5 years, but certainly if there's a change of care venue, a change in medical condition, any other major life events. Patients with capacity can request alternative treatments or revoke a POLST at any time, and so can the legally recognized decision maker. They may request a change from the POLST based on a condition change. Somebody may get better, or there might be a really bright prognosis, and maybe we want to leave them on the ventilator for another few days. It really is dependent upon the situation and a person's change in condition. Once it's completed, really important, the original stays with the patient. It should be on their refrigerator, on the back of their door, any place where paramedics could see it easily, sometimes under the phone and the kitchen counter, an easy to find location, and make sure it's in their medical chart. Make sure copies get made and distributed, because this form should follow the patient all through the continuum of care. It can be photocopied. It does not always have to be on the pink paper, but this is what is considered to be the best practice. And copies, faxes, screenshots, all are legally actionable. It really is more than a form. It facilitates these rich conversations about goals of care and patient desires. It's the complement to the Advanced Healthcare Directive, and it incorporates the importance of treating patients who are very, very seriously ill and attending to their comfort. So we've done poll question 3. Most of this curriculum comes from the Coalition for Compassionate Care of California. And this new education program, the POLST Champion, has recently been launched. And I have put the website into the chat because I think it's a very, very excellent curriculum. And even though there's a significant fee attached to it, if you are having these conversations, it's an important part of your development. So this project is very important that we have conversations, community collaboration, that throughout the state of California, we have a consistent form that is standardized so that it is recognized all across the continuum of care, and that we promote excellent conversational skills among our healthcare providers who would be explaining these options to patients and their families. You can purchase the POLST form. I can give you a few, but most folks purchase them from this website at MedPass. And it's a great idea to have some on hand so that you can have conversations when appropriate and not have to look for the forms. So there's lots of resources. There's lots of decision guides. There's FAQ sheets. There's lots of things that can help you as you are getting more comfortable making sure that people have their wishes codified in an actionable medical legal form so that we can honor their wishes in the event of very serious illness or a catastrophic accident. So thank you. So glad you're interested.
Patty, thank you so much for that valuable lecture. We can all use this information, even those of us who know it. It's good to get it reinforced. So let me just ask you all at this time to go ahead and put any questions that you have for our presenter into the chat box. And while you're doing that, I want to mention just a couple of workshops that are coming up, webinars that you may be interested in. Our next monthly webinar takes place on June 10th, at 11:30, the standard time, and I'll be the speaker and I'll be talking about enhancing everyday activities in dementia care. Also, on the next day, no, actually, June 12th is the World Elder Abuse Awareness Day for 2025. And to learn more about these topics or any of the other education that we provide, you can go to our website at www.alzoc.org. Now, let me just take a look. Some of the questions that are in the chat box were answered in the course of the conversation. For example, someone was asking if the screenshot for a family member is legal, and you said that was definitely actionable, correct, Patty?
Correct.
Okay, and then someone followed up by asking, is there a California registry?
There isn't yet. It is in the pilot form. There has been legislation and some funding going to an electronic POLST registry. And we are very, very hopeful that in the next 2 years it will be available, but it's still in the pilot testing form.
Thank you, Patty.
Good question.
Is the pick not voluntary at a sniff?
That depends upon the sniff. In some cases, it's something that is done with every patient that's admitted, preferred intensity of care. So that's going to be a policy at each sniff because the PIC form is only valid for that stay in that facility. So it's a very limited document.
Thank you. Going back to the pulse, does it require two witnesses?
No, it does not.
Okay.
The Advanced Healthcare Directive requires either notarization of the patient's signature or two witnesses to attest that they are known to the patient. And those two witnesses should never be anyone involved in the patient's medical care, anyone who might be a beneficiary of that patient's estate or have a stake in how their care is operated. So somebody working for the hospital, the SNF, the assisted living, the home care agency, those folks should not be witnesses to a person's advanced healthcare directive.
Thank you. Patty, do you recommend bringing in family or significant others, bringing them into the conversation when making a pulse with the doctor? Or should this be a one-on-one conversation between the doctor and the patient?
That is a really
Yeah, that's a
excellent,
great one. Yeah.
thoughtful question. And the answer is it's going to depend. What's the patient's cognitive capacity? What does the patient want? If the patient has full capacity and wants to execute this privately, that is something we should honor. But if it's questionable, or if you're not sure if the patient really, they might have full cognitive capacity for decision making, but they may not understand all the clinical terms, or there might be a language barrier. So that's got to be decided on a case by case basis. Certainly, if English is not someone's first language, there are POLST forms printed in many other languages, but they must have an English copy that absolutely mirrors what the other language copy says, stapled to it and readily available. So there's lots of different provisions to help people who may have compromised opportunity to understand the entirety of the clinical conversation. You just have to decide that on a case by case basis. You might have family member that appear to be loving and caring about the patient, but they may be hoping that grandma's estate is going to get settled sooner than later. So they may not be completely objective in following what grandma might want. And what you don't want is for relatives to be saying, oh, grandma, you wouldn't want that, would you? Or grandma, of course you want to stay alive because we want to collect your social security check. So people could have motives that are not 100% altruistic. So it's got to be on a case by
Absolutely.
case basis.
Okay, people are asking again for the site to get the post form, and I can tell everyone that that's www.capolst.org.
And I just put the website for Coalition of Compassionate Care in the chat again.
Okay. Let's see. Will a sniff require a PIC be completed if they feel the patient may die within the next year?
That's going to depend upon SNF protocols and standard operating procedures because I have seen it be different from facility to facility and who owns the SNF. So generally, if it's owned by a major corporate chain, the standard operating procedures are going to be the same in each facility, but that could be different.
Okay. One more question. You mentioned qualified POLST facilitators who can help lead the discussions. How did they find them? We didn't see that on the website.
Well, it's who has had the training. So a physician who deals with serious illness has probably had some training along the way that would qualify him or her to have this detailed conversation. Conversely, and what I have seen happen is sometimes a much lower level staff member, a social work designee, a business development person from a hospice, um, all of that is very concerning because unless that person has undergone a certification training that allows them to really know how to have a pulse conversation, it's inappropriate. There's no teeth to this. There's no enforcement right now. It's good faith and people doing things in a best practices kind of way, but there's no enforcement. And that's part of why the education is so important.
Absolutely.
So if I were in your shoes, audience, and you were going to have a pulse conversation, I would make sure I got specifically trained to be a pulse champion so that I would feel very confident in having that conversation. One of the things I did 15 years ago was go through the program at Cal State San Marcos in palliative care chaplaincy because as a non-clinician, it enabled me to have tremendous training on how to have a pulse conversation. But that was a full semester long class. There are these classes for nurses, for social workers, and other disciplines in healthcare. I think it's very important to invest in appropriate training and not delegate this to people who really are not comfortable with this entire conversation.
Thank you, Patty. Let's do one more question and then we're going to let everybody go. And we thank you for your time and attention, everyone. If a pulse needs to be changed, do you recommend making a whole new one for the sake of preserving clarity? Does one being changed mean the process happens again? Um,
Oh, that's
vis-a-vis
an
conversations with the doctor, PA, NP, whoever the person is that signs.
yes. If you're going to revoke or change an existing post, you want to have the complete conversation again. You want to line through the old
Mhm.
post and attach it to the new one. And then healthcare professionals will honor the one with the most current date. But yes, you want to start over because just because somebody says, I've changed my mind, we want to ascertain, do they really understand what this new choice means? So it's not, oh, okay, yeah, we'll just check a new box. It's not that simple. You really do have to have the conversation again. And in order for it to be legally actionable, it must be signed and executed exactly as if it was a brand new form.
Great. All right. Well, thank you again, Patty, so much. That was just a great topic, very valuable for all of us here. Um, Useful information that I think everyone really appreciates and appreciated having you today to talk about that. So this does bring us to the conclusion of our webinar.